I'm Jang from Boston, the United States. And
My name is Akasaka from Wakayama, Japan.
Park from Korea.
And Gregg from New York.
so today we are going to talk about how to detect and treat vulnerable plaque, a very hot topic. It was very popular probably 20 years ago and sort of, disappeared and now rapidly coming back. Very exciting. So we'll go over slides prepared by S.J. Park. So the issues are how to identify vulnerable plaque, definition and classification, and vulnerable plaque detection by invasive. We are not going to talk about non-invasive today, and how to treat vulnerable plaques, and natural history studies of BP, and ongoing trials. Ongoing trials, both Drs. Stone and Park will discuss. So vulnerable plaque, so there are three underlying mechanisms of sudden cardiac death, acute coronary syndrome, including S elevation and MI. Plaque rupture responsible somewhere between 50, 60, 70%. Erosion somewhere between 25 and up to 40%, and calcific nodules 3 to 10%. So in the old days, the definition of vulnerable plaque, we used to say plaque that is prone to rupture but has not yet ruptured. But I think that definition has to be altered now, right? Plaque that is prone to be disrupted with occlusive thrombus formation, right?
How about just prone to thrombosis?
That's good. But
All
I
right.
think we have to add time factor there, right? If plaque will get disrupted and form an occlusive thrombus 10 years from now,
Yeah, well,
you are not going to act on it, right?
right.
So some time factor, whether that's a 3 months, 6 months, don't know. What was your feeling on the basis of your study?
No, it's depend on the condition, so
Condition.
very difficult to predict the timing. Yeah.
And your clinical trial list?
Well, in Prospect, we were able to identify those lesions which were likely to rupture within at least a 3.5-year period. So
Right.
I think you can go a little farther out than several months.
Really? Okay. So plaque that may cause problem, let's say 4 years from now,
Yeah.
you want to treat now, locally, segmentally?
That's the question, isn't it?
Okay. So what are the components of vulnerable plaque? Necrotic core, fibrous cap, less than 65 microns, increased macrophage density or activity, increased vasoviscerum, and positive remodeling. If you were to pick 1 out of 5, what is it? Correct?
I don't know if there is just one of the 5. I think, my gut tells me it's a thin fibrous cap. And these are the morphologic components for rupture, specifically, as opposed to erosion, which I
Right.
think is different.
Totally different.
But for rupture, I think you probably pretty much have to have a thin fibrous cap. Although we don't really understand yet what the triggers are to rupture. It's probably got to be a metabolically active thin fibrous cap with macrophage infiltration, which is producing metalloproteinases and other enzymes, et cetera. There may be microcalcifications that should be present to destabilize the fibrous cap. So it's actually very complex.
Yes.
And-
Everybody agrees that fibrous cap thickness?
Yeah.
Okay. So, as I mentioned earlier today, we've been interested in erosion. But when you are detecting a vulnerable plaque, do you exclude erosion-prone plaque, or are you trying to include them? SJ?
Actually, so you just mentioned about, just one publication about the erosion concerned by OCT findings. However, I more agree with the opinion in terms of front thrombus concerns.
Right.
It's a rupture or erosion is a front thrombus. There is more, reasonable.
But as
concern.
I showed you, the plaque that had caused erosion doesn't have much lipid, doesn't have frequent TICFA, macrophage, cholesterol crystal, all very different from rupture-prone plaque. So you are going to target certain things. It can be lipid, it can be plaque burden, but plaque erosion, which is responsible for 40% of events, they have totally different pathology, totally different underlying mechanism. So when you are designing a study, you want to first detect vulnerable plaque.
Yeah, I think the answer is we would like to be able to detect erosion-prone plaques, but we don't know how to do that.
Right.
In fact, the way we diagnose an erosion right now is that it's got to have an associated thrombus with it.
Exactly.
You know, because even OCT is not, you know, accurate enough to see just a thin eroded layer of endothelial cells.
Exactly.
And the underlying, you know, structure of that plaque, it's often proteoglycan rich. We don't have any technique that specifically looks for proteoglycans. Sometimes there's lipid pools and sometimes there's atheromas, but that's non-specific. So right now we're primarily trying to detect thin-capped fibroatheromas.
Right. So that excludes up to 40% of target
Yeah, I
population.
don't know that it's 40%.
You know, our study
it's,
2738.
Yeah, it might be 25%.
You know, still substantial, 1/4.
Yeah, it's not 0. It's not 10.
Okay. So this is a typical, you know, Ranu-Vermani sort of slide. So we are targeting TICFA basically, right?
Pretty much.
Yeah. So, Greg, you want to spend a few minutes talking about your study?
Oh, sure. You know, we did a multimodality imaging study to try to identify which untreated lesions, which usually appear mild angiographically, would be likely to progress rapidly, rupture, and cause acute coronary syndromes in the future. So this was Prospect, and we took about 700 patients who presented with an acute coronary syndrome. We chose acute coronary syndromes because we know they usually have ruptured thin-capped fibroatherosaroma already, and we know that they'll be more likely to have other untreated thin-capped fibroatheromas. We know that pathologically. So they had to undergo successful treatment of their acute coronary syndrome in addition to treating any other lesions that the operators were going to treat in the coronary tree, after which point we then performed 3-vessel imaging of the proximal 6 to 8 centimeters of each coronary artery, and we followed the patients on maximal medical therapy for a median of 3.4 years. And what we found was that about 20% of the patients, about 1 in 5 patients over 3 years, had an acute coronary syndrome event. That's cardiovascular death, myocardial infarction, cardiac arrest, or unstable or progressive angina requiring hospitalization. And about half those events came from the treated culprit lesions. So that's either stent thrombosis or restenosis. But about half the events came from untreated so-called non-culprit lesions. And those lesions were about 30% stenotic by QCA at baseline, progressed to about 65% at the time of their event, often with plaque rupture and with a new thrombus present. We also had an important 2.7% of events, most of which were sudden deaths, and those were most of the deaths in the study, in which we didn't have an angiogram, and so we couldn't attribute those to either treated culprit lesions or untreated non-culprit lesions. And so when you look at the event rates that were due to non-culprit lesions, you could see there were very few deaths or myocardial infarctions, but that's probably because most of them were in that green curve, the non-culprit lesions that we couldn't assign. Most of the events were not deaths or myocardial infarctions. Most were unstable angina, and that's because these patients were pretty much all on aspirin, clopidogrel, beta blockers, ACE inhibitors, high-dose statins, really good medical therapy. So they'd rupture a plaque, they'd have thrombus, but they'd have a 98% stenosis. It was just enough to keep the blood flow going, and that shows you how important secondary prevention is. And when we did multivariable analysis to look at the untreated non-culprit lesions, we found the 3 main events that predicted it. Number 1 was plaque burden, greater than 70%. Less than 70%, very unlikely to have an event. Greater than 70%. So that really exploded the myth of the mild vulnerable plaque. You know, angiographically, these lesions look mild, but that's because the angiogram is a terrible tool at telling how much atheroma there is. So most lesions that cause an event were quite bulky with positive Glegovian remodeling. The second risk factor was a TICFA, as defined by virtual histology, a thin-capped fibroatheroma. And then a minimal luminal area of less than 4 millimeters squared was the third area. Again, despite the fact that by the angiogram these were 30% or 20% diameter stenoses. And when you started to look at the combination of those events, then you can get very high event rates over a 3-year follow-up period, anywhere from 16, 18% or so. And that's when we start thinking about treating, because you might think that, well, if these are lesion-specific event rates. So if I've got a lesion that's got a 16 to 18% event rate, I can probably do better with a drug-eluting stent, let alone a bioresorbable scaffold, by treating that lesion over a 3-year period. So I don't know, you want to go on to...
We can skip this.
Yeah, other studies, have since shown the same thing. Atheroma, atheroremo, using, again, with IVUS and with near-infrared spectroscopy, showed that a TICFA, again, with high plaque burden, was a predictor of early events, whereas a TICFA with lower plaque burden was a predictor of later events, suggesting that you probably need multiple plaque ruptures before you get to an occlusive state. And VIVA basically found which was a single center study, smaller than Prospect, but found basically the same thing, that plaque burden and TICFAs were the most important, and remodeling also may be somewhat important as well.
Yeah, this I guess we can skip. And the next, I think you again. So on the basis of Prospect, and you designed Prospect 2.
So now we're doing Prospect 2, and it's got two goals. The first is to validate near-infrared spectroscopy as a prospective tool to be able to identify vulnerable plaque. NIRS is, of course, very accurate to identify lipid. Now, that could be necrotic core or it could be lipid pool, and it doesn't depth resolve where the lipid is. But on the other hand, it seems to be the signature of events that cause myocardial infarction. So we're very hopeful for this technology. It's also very easy to interpret, unlike virtual histology. So we're doing basically a prospect type study in 900 patients in a collaboration with our friends in Sweden, Denmark, and Norway with the SCAR group. And what we're also doing is, now that we've validated plaque burden as being predictive, we're taking plaques. Actually, now it's going to be with 65% or greater plaque burden, to be able to get more experience. And we're randomizing those 1-to-1 to either an absorbed scaffold or just guideline-directed medical therapy, to see if we can safely put in the scaffolds in this pilot study in, quote, vulnerable plaque. These are going to be, again, 10, 20, 30% stenoses. And we're bringing all those patients back for 3-vessel repeat NIRS IVUS at 2 years to see if we've enlarged the lumen, and again, that we have a low MACE rate. And again, all these patients will be followed for more than a decade in the SCAR register.
Thank you. So I did a little bit of homework.
Okay.
Actually, I reviewed the slides that
Okay.
you kindly provided
Okay.
from New York to Boston. So right after Prospect, according to you, the question was, following successful PCI in patients with ACS, is 3-vessel VHI, was you may not remember,
Right.
identify prophylactically treat non-infarct lesion at high risk? And your answer at that time was no, for 3 reasons.
Right.
The prevalence of high-risk lesion is low, 1 in 4 patients. 3-vessel imaging is not without risk, 1.6%. When high-risk lesions become symptomatic, they usually present with angina, not sudden cardiac death and MI. And one more. Another question was, so what should our effort for future investigation? You said, forget invasive, it's got to be non-invasive. What made you change?
No, I think you're taking my responses a little out of context. So right now, I don't think we have any evidence that says we should treat vulnerable plaque. Because there's a lot of unknown questions. Again, there's the risks of imaging, there's the risks of the procedure itself, of the scaffold, there's risks of distal embolization from treating them, et cetera. And we don't know the temporal stability of these things. We don't know how many we can find, and therefore whether we'll change the prognosis for the overall patient, let alone for just one lesion. That being said, I think it certainly should be investigated. And so my answer to that question was, don't do it today unless the patient gets enrolled in a study
Right.
to see if it's overall going to benefit the patient. And in terms of the non-invasive, I mean, ultimately, I don't think that 3-vessel imaging is a practical tool to use in all patients. We may end up using it in very high-risk patients, but how do we find those high-risk patients? I mean, ultimately, if we're going to make a big impact on the scourge of sudden death and myocardial infarction, we've got to identify patients who aren't being treated, who don't know they've got this disease, and then consider how to treat them, either with more potent systemic medical therapies or maybe something like this, if they have 1 or 2 lesions. And there we're going to need non-invasive imaging as a screening tool, maybe in patients with high Framingham risk scores or CRPs or something of the sort.
Okay, thank you. Another very important study is planned, SJ. Can you show the next slide and tell us briefly about your study?
Actually, all right. I just follow the Gregg's concept. However, I would define the palatable plaque itself as. However, I would combine the functional concept as now our practice concern. FFR guided diagnosis, FFR guided treatment concerns 1A, 1B guideline. And so I would combine the negative FFR, however, pretty much palatable plaque, and would, randomize it BBS and the optimal medical treatment. That is, just follow the Gregg's concept. However, I would like to combine the
I think that was
negative
very
FFR.
smart to introduce FFR with current guideline as well. So both are going towards direction local detection and possibly local treatment, right? Your study, easy fit, right?
All right.
So that's the dose we never use in the United States, by the way.
Right.
What was it, Lipitor 5 and
Yeah.
20?
20,
Yeah.
that's right.
So the current practice, at least in the East Coast, someone comes in with ACS or even coronary artery
Right.
disease, we start with so-called high-intensity statin therapy,
Right.
Crestor 20/40 or Lipitor
I
80.
know.
That's how we start, boom.
Yeah.
That's a secondary prevention.
Right.
And primary prevention with the new guideline, basically everybody over 50 has to be on statin. So we are really maximizing both secondary and primary prevention.
I know.
And your study showed even with much lower dose
Yeah.
than what we use in the United States,
Right.
you can relatively rapidly stabilize the plaque.
Yes.
And you measure fibrous cap thickness. And Gregg mentioned, let's forget erosion, which is tough to diagnose, especially before the event.
Okay.
If we target rupture-prone plaque, fibrous cap thickness is the most important target.
Right, yeah.
And you showed we can quickly stabilize this.
Right.
Do we still have to pursue this local detection?
I think, first of all, I would like to talk about the dose. In Japan, the people are so sensitive to the statin. Also, the body weight is completely
Right.
different in the Japanese old lady and the European or American big gentleman, right? So, drug should be depend on the body weight first, right? So, for us Japanese, 20 milligram is
Equivalent
yeah,
to the-
equivalently to the 80 milligrams for the European people, I think. And there are 2 ways to approach the vulnerable plaque, right? One is whole body approach. I mean, as you may agree, the vulnerable plaque not only limited in the one portion, it's a pan-vascular event. Therefore, we have to think about not only the coronary, but also the other vessels at the same time. Therefore, the drug should be very important to approach to stabilize the vulnerable patient first. But also, the prediction of the event at of the vulnerable plaque also very important. If the rate of the event is very high, and also the treatment complication is very low, the patient may have the advantage to have a local treatment. So it's depend on the benefit and the risk.
So we also go ahead.
Right. I totally agree with the Akasaka's data. Says we just finished our another randomized study to compare with a high dose actual starting 40 millimeters and 20 millimeters to evaluate the longitudinal imaging studies. It clearly demonstrate plaque regression and polytopic plaque component regressions, and actually we didn't find any difference in
Between
high dose
20
between the
20 and 40?
high dose and moderate rosuvastatin. The meaning is just Akatsuka mentioned about the small body mass index and the ICM people, so we don't need too much high dose. That is one thing. Second one, statin actually have some acute effect. We follow the 1 year. It's just related with the changing of a polytopic plaque itself. It's not only related with the low LDL levels. So you may understand it's more anti-inflammatory effect, and also so we have some published data. Even in the plaque itself, we when we do the directional hysterectomy concerns, we harvest lots of asthma plaque. We find the plaque is polytopic plaque has some lots of HMG-CoA reductase expression in the plaque itself, and so acute phase statin stabilize the plaque itself too. So
sure.
I believe it's not related with the long-term effect or low LDL, just direct inhibition of plaque itself and anti-inflammatory effect may related.
So the more unstable the patient is, the more effective and rapidly you can stabilize plaque.
Well, there are pleiotropic effects of
Yes.
statins, right? There's
Yeah.
an antiplatelet effect, there's an anti-inflammatory effect, there's, so
So
I agree with
we
that.
also finished the study, statin naive patient. We did all CTIVs and then repeated all CTIVs 6 months and then repeated after 12 months. Vast majority of patients who were statin naive, fibrous cap thickness doubles in 6 months. So that's why I ask you timeline, definition of vulnerable plaque. Are you talking about 3 months? Are you talking about 5 years?
Yeah.
So if you can stabilize, fibrous cap within 6 months, in vast majority, almost 100%, do we really need to try to find vulnerable plaque?
Well, let me point out that, again, in Prospect, 98% of patients were on high-dose statins. And you remember the Prove It, I think it was TIMI
Yes.
22 study, which was 80 milligrams of Lipitor versus 40 milligrams of pravastatin. And there was this was a clinical outcomes trial. There were fewer acute coronary syndrome events during follow-up with 80 of Lipitor, but it was still about a 25% event rate over 2.5 years. So similarly, we saw in Prospect, in probably the most carefully followed and well-treated patient population, only a 12% 3-year non-culprit lesion event rate, so 4% per year, not a lot. But on the other hand, we could find lesions that were having, much higher event rates than that. So I'm not saying that every patient has to have vulnerable plaques treated, but I think that there are patients, even who are optimally treated, who are still going to have events on high-dose statins and guideline-directed medical therapy that we may be able to help
With a local treatment, in
with local
addition to.
treatment. Perhaps. I don't think we should do it
Right.
today,
You
but
need
it
to
needs
test.
to be well studied.
Okay. That's how you feel, I assume.
Right.
Yeah.
So, anyways, almost in concept, the reason why is we want to have some,
Is this kind of approach
Right.
feasible in Japan?
Yeah, I think so. In our institution, our data demonstrate between FFR 0.75 to 80, the event rate for 3 years in our institution is about 16%, right? So thinking about the 6% event, if we do the treatment, the first year might be 7 to 8% in Japan, and then 2 to 3% per year after the first year. So maybe more than 3 years, the treatment should be better. The stenting should be better. So we have to have the data about the FFR more than 0.80. We do not know, but we have to think about first the 0.80 to 0.85 or 0.85 to 0.90, and then we take into account the other imaging data to predict the future event, right? And if the event is much higher than the risk of the intervention, we have the chance to treat, right?
And a lot of that depends on how you define periprocedural myocardial infarction. You know, I mean, if you define it by a small troponin elevation after the procedure, then
I agree.
you're going to have a lot of events. On the other hand, if you define it as a clinically relevant myocardial infarction with the SKY definition, that should be no more than 1% of procedures.
So one last question to each of you. So I mentioned this paper, The Myth of the Vulnerable Plaque, by Armin Zadeh and Valentin Fuster. So what they propose basically is let's not try to find local, let's go systemic plaque burden. Comment?
Well, I mean, again, I agree that's the first step. We need to identify the high-risk patient. I think it's well established that, you know, acute coronary syndromes and sudden cardiac death is demonstrating that coronary artery disease is a focal manifestation of a systemic disease. So I think the screening that Valentin is doing identifies the high-risk patients. And of course, we're going to treat those patients with maximal medical therapy. But, you know, even almost a decade ago now, Eugene Brunwald realized that you know, we have Brunwald and Fuster, so battling, two giants battling head-to-head. And even he realized and published in JACC about a decade ago now that even that may not be enough for the ultra-high-risk patient. And the question is, should we be looking to identify that patient? And I think, you know, SJ and I and Ron Waxman, we're trying to start to see if that's feasible, if that's something to do.
Right. Same concept.
Systemic,
systemic illness and local manifestation have a still, we have to define a small number of base concerns, deaths, and MIs.
Do you believe the Japanese people or Asian people rather have lower incidence of vulnerable plaque?
No, the success rate of secondary prevention should be higher than the American or European people. So I'm not sure the reason why. It might be the lifestyle or the drug, but anyway, I'm not sure in the Japanese patient, but in United States, the failure of secondary prevention might be 1/4 of ACS. So we have to still target on that patient because we already administer the statin or other vascular protective drug, but still we miss the 1/4 of ACS. Right.
Okay, anybody has last comments? Okay, we'll wrap this up. Thank you very much.